This is Dr. Mansoor Madani, Chairman, Department of Oral and Maxillofacial Surgery at Capital Health System in Trenton, New Jersey, and Associate Professor, Department of Oral and Maxillofacial Surgery at Temple University Hospital in Philadelphia, Pennsylvania. I'm going to continue to speak about pediatric and adult medical emergency, prevention, preparation, recognition, and management. Medical emergencies may be infrequent in the dental setting, but because the possibility always exists, we should never be complacent about this issue. Cardiovascular as well as cerebrovascular emergencies are life-threatening situations that must be recognized immediately to avoid delay in treatment and to minimize morbidity and mortality. Patient may present with uncontrolled hypertension, severe arrhythmia, history of heart attack or stroke, and on multiple medications. On the other hand, patients may present with no apparent issues until you start your procedure. The stress and anxiety that some patients anticipate during a dental visit could precipitate a medical emergency by itself when pain control is inadequate. A well-trained dental team can save a life, not only the life of the patient, but the life of everyone in the office, including people that accompany the patients, co-workers, and even the doctors. My hope is that by reviewing some potential medical emergencies in dental practice, I will provide some baseline or guidelines, creating a suggestive practice protocol to empower my colleagues and their team to be ready when an emergency situation arose. In this course, I will continue to discuss rare but deadliest complications that could happen during the course of a dental treatment. Based on CDC studies, in 2019, over 30 million people have cardiovascular diseases in the United States. 1 person dies every 36 seconds in the United States from cardiovascular disease. Amongst non-communicable illnesses, cardiovascular diseases rank number 1 cause of death in the United States. On the other hand, according to the CDC, every year more than 795,000 have a stroke in the United States. Someone has a stroke every 40 seconds, and every 4 minutes someone dies of a stroke. With so many patients affected, having various forms of cardiovascular diseases, dental practices will regularly treat patients with diagnosed or undiagnosed cardiovascular as well as cerebrovascular conditions. In part 1 and 2 of my presentation, I discussed the steps in preparation, prevention, and management of medical emergencies in general and reviewed a variety of scenarios regarding patients with hypertension, hypotension, syncope, and several other topics. And I hope that you had the chance to listen to those parts already. So let's continue with reviewing a few more scenarios, starting with the cardiovascular emergencies. Our first patient is a very apprehensive 65-year-old overweight man claiming to be healthy and present for oral surgical procedure. His blood pressure is 145/83 with a heart rate of 102, respiratory rate of 18. You begin his procedure with topical anesthesia and then continue with local anesthesia. As you wait for the anesthetic to be effective, you look at him. His face is pale. He tells you that he is nauseous. You touch his forehead and is completely wet and he is sweaty. After a few moments, he complains of indigestion and gas buildup in his chest. He tells you that he has pain in the middle of his chest. Then he adds that he can even feel the pain in his left shoulder, arm, neck, and his lower jaw. His blood pressure now has dropped to 90/50 with a pulse rate of 41. What would you do? What is your diagnosis? You have already checked his history and took his vital sign. He has told you that he never had any problem I'm not even taking any medications, he told you. He also said that he does not even need to go to a doctor. And this line is always a warning sign for me. When a 65-year-old overweight person tells me that he never goes to a doctor and has no medical problem, many times after further questioning, they will tell you more about their health issues, such as high cholesterol, hypertension, diabetes, and sleep apnea, which are common among this group of patients. So we have a poor historian with those symptoms. Would you let him drive home by himself or activate EMS or emergency medical services and transfer him to an emergency room? A smart practitioner will not allow him to leave the office by himself, monitor his vital sign, and take all appropriate actions as needed. But first, and most importantly, is to diagnose his problem. If you only consider chest pain, there are tons of differential diagnoses, including but not limited to anxiety, musculoskeletal diseases, angina and myocardial infarction, pulmonary embolism, hiatal hernia, gastritis, gallbladder diseases, to just name a few. But remember, he also stated that the pain radiates to other parts of his body, like his left shoulder, back, arm, neck, and lower jaw. Now let's narrow the list. Of course, any of those could easily be the diagnosis. Anxiety, angina, myocardial infarction, cardiac arrest, pulmonary embolism. But his symptoms are in line with cardiovascular issues, and my first assumption is angina. Acute chest pain that occurs during dental treatment may be an infrequent event, but the underlying pathophysiology can be the source of dire consequences, especially if immediate action is not taken. Angina and acute myocardial infarction are the two most likely cardiovascular source of chest pain, and that develop in a conscious patient while undergoing dental treatment. Anxiety and panic disorder are also potential causes of chest pain, although the seriousness of possible myocardial infarction requires that any report of pain to be considered a medical emergency. The early symptoms of angina may include chest pain and discomfort, or patients may say, I just don't feel good, feel dizzy or nauseous, having a feeling of indigestion. Some patients may feel heavy squeezing pressure, burning or fullness feeling in their mid-chest area, and they may have shortness of breath. Pain in angina may be of short duration, lasting between 5 to 15 minutes if the provoking stimulus is stopped or if the nitroglycerin is used. Skin pallor, sweating, fatigue, pain in the arm, neck, jaw, shoulder, or back are also common. As the time passes, the late clinical finding of angina may include any of the following: crushing, squeezing, constricting pain, feeling of tightness, pressure in the chest, heavy substernal pain, pain that lasts from few seconds to few minutes, hypotension. Patients, they could even become unconscious. So what causes angina? Simply said, angina is caused by reduced blood flow to the heart muscle. And of course, blood carries the vital oxygen that the heart muscle needs in order to function or even survive. When the heart muscle isn't getting enough oxygen, it becomes ischemic. In other words, we develop angina when there is reduction of the blood perfusion and oxygen supply to the myocardium, but not complete blockage of the coronary arteries, so the myocardial cell weakens but do not die. If there is a complete blockage of the coronary artery and those tissues of the heart are affected and become necrotic, then it leads to myocardial infarction. The most common cause of angina is the coronary artery disease, or CAD. Plaque buildup in blood vessel of the heart causes coronary arteries to narrow, limiting blood flow to the heart Unfortunately, coronary artery disease may be totally asymptomatic, but when the oxygen supply to the heart is reduced, then the symptoms will develop. Angina may be classified as a stable angina or unstable angina. Patients with stable angina experience chest pain when physical activity and or emotional stress, anxiety, or even sudden exposure to cold causes a metabolic demand on myocardium that the existing supply of oxygenated blood cannot meet. For these patients, a sublingual tablet or a sublingual metered spray of nitroglycerin will relieve the pain within a few minutes. On the other hand, patients with unstable angina experience cardiac-related chest pain even while at rest, because these patients are at much higher risk of adverse cardiac event such as an acute myocardial infarction, ventricular tachycardia, or ventricular fibrillation and arrhythmias. They should not receive dental treatment until their unstable angina is treated. Emergency dental treatment of patients with unstable angina should only be done in an environment in which all vital signs can be monitored continuously and in which emergency medical assistance is immediately available. A hospital setting, whether inpatient or outpatient, may be necessary. Medical management of angina includes the following. The first step is identification and treatment of associated disease such as managing obesity, anemia, hyperthyroidism, and sleep apnea, and so on. Importantly, reduction in cardiovascular risk factors such as smoking cessation, control of hypertension, and hyperlipidemia should be considered. Also, lifestyle changes such as weight loss, exercise, and salt intake restriction is important. Management will depend on the type of angina and other factors. If the angina is stable, it might be controlled with lifestyle changes and medication. Unstable angina may require immediate treatment in a hospital setting, which could involve medication and surgical procedure and revascularization. Pharmacological management of angina includes use of nitrates. Nitroglycerin is a vasodilator and causes the relaxation of a smooth muscle of the blood vessels. Vasodilation occurs in venous and arterial beds and coronary arteries. The ultimate effect is a reduction in systemic vascular resistance and left ventricular pressure, which reduces the myocardial demand for oxygen. However, this vasodilation effect can interact synergically with other medication and causes unpleasant and even dangerous and deadly effects. For example, male patients who are currently taking medication for erectile dysfunction such as Viagra or Cialis can experience a significant or profound hypotension when these medications and nitroglycerin are combined, resulting in unconsciousness and even death. There are numerous other medications used to treat angina, including antiplatelet agents such as aspirin or Plavix, beta blockers such as metoprolol, calcium channel blockers such as amlodipine, cardizem, and nifedipine, and verapamil, to name a few. Mechanical revascularization includes angioplasty with a stent placement or coronary artery bypass graft surgery. They all could be considered. How about emergency management of angina in dental office? As I've said it in previous presentations, prevention is the key factor. Taking a thorough medical history is just the beginning. Monitoring vital signs continuously and placing the patients preoperatively in a comfortable position. An acronym that is frequently used to treat angina emergency in dental offices is ONA, O-N-A, which simply stands for oxygen, nitroglycerin, and aspirin. Patients who have been diagnosed with a stable angina usually are aware of the event that will precipitate an angina attack. The stress and anxiety that some patients anticipate or experience during dental treatment can be one of such factors. So try to address that by considering supplemental sedation or nitrous oxide. Patients with a known history of angina or even heart attack should be asked to bring their own nitroglycerin tablet or spray to the dental office. After nitroglycerin tablets are exposed to air or light, when their container is opened, the shelf life is significantly reduced. My recommendation is, if you opened a bottle of nitroglycerin, do not put it back in your emergency crash cart, as nitroglycerin tablets are very inexpensive. Order a new bottle or order a sublingual nitroglycerin spray, which may be used until the expiration date listed on its original container. It is usually good for up to 3 years, even if you use it once or twice. If a patient with a history of angina experiences chest pain, obviously the dental procedure should be stopped immediately, and the patient should be placed in a comfortable position and placed on oxygen. Administration of 0.3 to 0.4 milligram of tablets of nitroglycerin or a metered spray of nitroglycerin as the initial treatment are the initial treatment of choice. This dose should provide relief of the angina-related pain in just a few minutes. If needed, the same dose can be administered twice more at intervals of 5 minutes. If the pain is not relieved after the repeated dose of nitroglycerin, you should consider that as a myocardial infarction and no longer an angina. Of course, additionally, 2 to 4 tablets of chewable aspirin could be provided to patients as well before it changes to myocardial infarction. Please remember that when using nitroglycerin, it should produce a bitter taste. Otherwise, that tablet is either ineffective or possibly expired. Oxygen and nitroglycerin should be used as your first choice of medication. Aspirin comes later if you suspect a cardiac event. Now let's talk about myocardial infarction. Early signs and symptoms of it may include a prolonged angina not responding to nitroglycerin, with continued symptoms of chest pain, feeling of impending doom, palpitation, shortness of breath. The pain can be like a clenched fist in the chest. Patient may even complain of pain at rest. Patient could complain about pain between shoulder blades, left arm, chest, jaw, upper part of the abdomen. They may have the following additional signs and symptoms: pallor, dizziness, fatigue, lightheadedness, clammy skin, cold sweat, weak pulse, heartburn, indigestion, nausea and vomiting, and finally patient can lose consciousness. But what are the risk factors that makes the patient more prone to have a heart attack or MI? Well, there are many factors such as obesity, hypertension, hyperlipidemia, with plaque buildup in the coronary arteries, chronic kidney disease, smoking, diabetes, a family history of cardiovascular problem, lack of exercise, poor diet, stress, and of course, age. The older the person is, the greater the risk. I have to also add another factor for survival. The chance of survival depends how fast you get the victim to the hospital for definitive treatment. Simply said, myocardial infarction may occur when there is mismatch between myocardial oxygen supply and oxygen demand. It occurs when there is a sudden blockage of major coronary artery from either a blood clot or bleeding into an atherosclerotic plaque. These are the most common causes of MI. When the supply of oxygenated blood to the myocardium is further reduced and the myocardial cells become necrotic, a myocardial infarction or heart attack occurs. Either of these conditions can occur spontaneously without any previous symptoms of chest pain, so you have to always be prepared. Symptoms of myocardial infarction are the same as angina, but with extended pain exceeding 30 minutes that is not relieved by ONA, oxygen, nitroglycerin, and aspirin. Now let's look at the causes of cardiac arrest, and they may include myocardial infarction, hypoxia, cardiomyopathy, extreme bradycardia, Wolff-Parkinson-White syndrome, which is an extra electrical pathway between atrium and ventricle of the heart causing severe tachycardia. Other causes are anaphylaxis, anesthesia overdose, severe hypotension, long QT syndrome, and ventricular fibrillation. First step, if one is suspecting MI, is to provide oxygen to the patient, activate EMS, and monitor the vital signs continuously. The medication used to provide initial life-threatening treatment for a conscious patient with myocardial infarction could be remembered by the acronym MONA, M-O-N-A: morphine, oxygen, nitroglycerin, and 2 to 4 chewable tablets of aspirin. Of course, placing the patient in a comfortable position and monitoring the vital signs are essential. I highly recommend to purchase a demand valve pictured here on the right for delivering oxygen to the patient's mouth and nose at the same time and in much more accurate ways. This is a really inexpensive and valuable piece of equipment that I do highly recommend, a demand valve. Morphine given by IM or IV route provides relief from the acute, crushing pain that accompanies a myocardial infarction. Although morphine has been recommended in patients suffering from myocardial infarction, there is a controversy regarding the use of it, as it has no benefit on the mortality of a victim. Use of narcotics such as morphine, however, during the early courses of myocardial infarction reduces anxiety, chest pain, and may even have some effect to reduce ventricular load by reducing heart rate and blood pressure and increasing venous return. So its use increases oxygen supply to the heart and at the same time decreases myocardial oxygen demand. I have to add that fentanyl appears to be a safe and effective alternative to morphine for the management of chest pain in the pre-hospital setting, such as our dental offices. So if you don't have morphine, you can change that acronym to FONA, F-O-N-A, which stands for fentanyl, oxygen, nitroglycerin, and aspirin. Because many dental offices may not have morphine or fentanyl available, you can put the patient on 50-50% oxygen and nitrous oxide to both sedate the patient and also to get some degree of relief of chest pain. Nitroglycerin or as a sublingual tablet or metered sublingual spray will act as a vasodilator, as I said earlier, and ultimately reduce the oxygen requirement of the myocardium. In a conscious patient, 2 to 4 chewable tablets of aspirin are recommended for antiplatelet activity of aspirin. I have to stress that the use of an automated external defibrillator or AED is crucial and life-saving step that any practitioner must take. Each dental office must have an AED. When used with the basic life support techniques of CPR, defibrillation can significantly increase the chance of surviving a myocardial infarction. Each minute that elapses before the heart is successfully defibrillated results in a 7% to 10% decrease in the chance of survival. Instruction on the use of these devices should be incorporated in the office training for all staff members, because the response time for EMS can vary. The dental office should be prepared to provide medical support for the patient until emergency medical services or EMS personnel can provide further assistance and transport the patient to the hospital. When neither a pulse nor breathing can be detected, obviously CPR should be started. What are the preventive measures and management of a patient with myocardial infarction in dental practice? First of all, the appointment must be short and always schedule the patient early in the morning. Place the patient in a comfortable position on the dental chair. Take vital signs before, during, and after the procedure. Make sure you have nitroglycerin available in the office. Limit the amount of vasoconstrictor as well as local anesthetic, but make sure patient is numb and is not in pain. Try to avoid epinephrine impregnated retraction cord. After the procedure and or surgery, use adequate pain medications. Now, let's explore the difference between myocardial infarction and cardiac arrest. Myocardial infarction is caused by blockage of major coronary arteries. It is a circulation of the blood to the heart problem. The cardiac arrest is caused when the heart's electrical system malfunction. Basically, it stops beating unexpectedly. Based on the last recorded statistic of American Heart Association in 2019, fatality rate of cardiac arrest is as follows. 475,000 Americans die each year from cardiac arrest. Over 290,000 cardiac arrests occur in hospitals each year in the United States. Survival to discharge from inpatient cases is 25%. Over 356,000 cardiac arrest, however, occurs outside of the hospital setting with 90% fatality rate. That's nearly 1,000 people each day. Survival for outpatient cases is only 10%. Classic early symptoms of cardiac arrest include pressure, fullness, heaviness, and a squeezing pain in the center of the chest that can radiate to neck, shoulder, jaw, and back, nausea, sweating, weakness, lightheadedness, unexpected wheezing, unusual fatigue, sudden onset of unusual shortness of breath during usual activity or at rest, belching, burping, indigestion, heart palpitation, new arrhythmias, dysrhythmias, especially atrial fibrillation. The late symptoms of cardiac arrest may include absence of carotid pulse, unobtainable blood pressure, apnea, cyanosis, ashen gray skin, dilated and fixed pupil, and finally, the patient could become unconscious. One of the most common questions asked by dentists is how long after open heart surgery can I do dental treatment? Of course, always consult the MD first or cardiologist. General recommendation is to wait for 6 months after open heart surgery, a stent or other cardiac devices, unless advised otherwise by the cardiologist. No antibiotic prophylaxis is needed after bypass surgery. The patient should not be taken off blood thinner for minor dental procedure. What are the preventive measures and management of all cardiac patients in a dental practice? Again, make the appointment short and early in the morning. Consider pre-medication with sedative. But you have to also, again, consult the cardiologist or physician about that. Also consider nitrous oxide or IV sedation during the procedure if trained to start an IV. Ensure comfortable chair position. Avoid reclining the chair for prolonged period of time or any time if patient is not comfortable. Consider using pulse oximetry on a regular basis. Make sure to take vital signs before, during, and after the procedure. Use nitroglycerin, have nitroglycerin available and use it as needed. As far as local anesthetic, limit the amount of carpules to 2 to 3 carpules of local anesthetic and limit the epinephrine in them to 0.04 milligram, 400ths of a milligram. Avoid use of epinephrine impregnated retraction cord and watch out for orthostatic hypotension. Have the patient stand up slowly. Anticoagulant treatment using Coumadin is very common for patients with cardiovascular issues. A test that is often used is the International Normalization Ratio, or INR. For a healthy person without anticoagulant treatment, the INR is 1. Anticoagulant treatment usually target to an INR between 2 to 3. In certain high-risk situations, such as patients with mechanical mitral valve prostheses, higher INR values of 2.5 to 3.5, even up to 4 may be required. The risk of thrombosis may be increased in patients in whom oral anticoagulants are temporarily discontinued. Please note that monitoring of INR is not routinely needed with the use of the new generation of anticoagulants such as Xarelto, Pradaxa, and Eliquis, and the anticoagulation effect of these drugs are much shorter than Coumadin. Rather than 5 to 7 days, they are just 2 days prior to your procedure. If practitioner allowed the patient to stop using Xarelto or Pradaxa or Eliquis or substances like those. Oral anticoagulant should not be discontinued in majority of patients requiring outpatient dental procedure, including extractions. The risk of bleeding versus cardiovascular benefit of anticoagulations must be carefully considered. Patient taking blood thinner should not be prescribed non-selective NSAIDs and COX-2 inhibitor for pain management following dental procedure. Basically, just give them acetaminophen or Tylenol. There are several local hemostatic measures that could be used for patients on blood thinners, and they may include placing a suture, using oxidized cellulose such as Surgicel, collagen sponges, gelatins of animal origin, thrombin and fibrin sealants, using electrocautery or laser bone wax, antifibrinolytic agents as well. I use a natural fiber cellulose such as blood stop, hemostatic gauze routinely on all extraction sites. Microscopic clotting agent particles are activated when they come in contact with blood. The sponge expands and creates a blood clot that seals the extraction site and prevents excessive bleeding. The hemostatic gauze could be purchased in a local pharmacy or online and are very inexpensive. A pulse oximeter is also another fairly inexpensive device that measures how much oxygen is in someone's blood. It's a small device that clips onto a finger or earlobe. It is generally used in a hospital and office, and now after COVID-19 pandemic, many people have pulse oximeter in their home to check the oxygen level in their body. The normal level should be over 95% saturation. So, in summary, always update all patients' medical history. If suspicious of angina or MI, place a single nitroglycerin tablet under the patient's tongue or use the nitroglycerin spray on the patient's tongue. It doesn't have to be underneath the tongue, anywhere in their mouth. This could be repeated every 5 minutes and up to 3 times if needed. It is important to check the patient's vital sign continuously. Don't forget to provide oxygen to the patient. Chewable tablet of aspirin, 2 to 4 tablets, is also recommended. Here's what you should provide to the emergency medical services or EMS. One of the team members should prepare a concise review of the patient's medical history, time of the event that occurred, vital sign reports, and the type of treatment provided, and if any medication were given. All of this information should be provided to EMS team. All action taken, including if CPR was performed, and the use of AED and the victim's response to your treatment should be provided also to the EMS team. Then ask them where are they taking the patient, which hospital the patient is going to be taken to. Call the ER to follow up, and definitely call the patient the next day or the family the next day as a follow-up. Now let's switch to another subject, cerebrovascular emergencies. A 73-year-old man present for dental treatment. Soon after the start of the procedure, he complains of a severe headache, feels nauseous and dizzy. His face looks asymmetric, as if he has facial palsy. He cannot fully close his eyes or pucker his lip on the right side of his face. Maybe he has facial palsy after injection of a local anesthesia that you just gave in the upper posterior maxillary area and got too close to the facial nerve. But then he also complains of vision problem, including blurred vision and double vision. What is your diagnosis? Does this patient have a transient facial palsy from that local anesthetic, or because it occurred so fast with a severe headache is something else, something much more serious? Maybe he has central facial palsy, which is the paralysis of the lower half of one side of the face. This condition is often the result of a damage to the upper motor neuron of the facial nerve in the brain. So please check the patient carefully. As you continue to talk to him, you notice that he cannot verbalize a sentence, and he also cannot swallow his saliva. When you ask him to raise both hands, he cannot lift the right hand. Obviously not an isolated facial palsy from local anesthesia. What if he also had convulsion and became unconscious? What would you do? If you suspected a stroke, you are correct. A stroke is the 5th leading cause of non-infectious, non-communicable death in the United States. Approximately 7 million adults in the United States have a history of a stroke. Of those, nearly 75% are older than 65 years of age. As the American population ages, the number of patients with history of a stroke who continue to seek dental care is considerably higher. Risk factors that were likely instrumental in the development of the initial stroke in dental office are severe anxiety in patients with pre-existing hypertension, history of coronary artery disease, history of chronic congestive heart failure, chronic kidney disease, history of cerebrovascular disease, to just name a few. Stroke occurs when the blood supply to a part of the brain is interrupted or reduced, preventing brain tissue from getting oxygen and nutrients. Brain cell begins to die in minutes. It is a serious neurological accident and major medical emergencies, so immediate treatment is crucial, and if not addressed, it can be fatal. There are many causes of a stroke, but the most common one are cerebral hemorrhage and cerebral ischemia due to sudden interruption of oxygenated blood supply to the brain. To save a patient's life, I want my listeners to remember, if they suspect a stroke, act fast. It happened that the acronym FAST, F-A-S-T, also is the way to diagnose a stroke, and it stands for the following finding. F for facial weakness. Can the patient smile? Does he have facial droop on that side? A for arm weakness. Can the patient raise both arms? Or let's say in this case, the right arm is weaker and patient cannot raise his arm. S for a speech problem. Can he speak clearly and understand what you say? T for test and time. As soon as he fails any of the above test, it is time to dial 911 and activate EMS. Because diagnosis of a stroke is so important, I like to introduce another way to remember the diagnosis of a stroke by using acronym BFAST, B-E-F-A-S-T, because it is so important to be fast. B for balance, loss of balance, sudden and severe headache and dizziness. E for eyes, sudden loss of vision in one or both eyes. F for face, which is uneven, looks like facial palsy. A for arm, face, and leg weakness, or even sudden numbness and trouble walking. S for speech difficulty, and finally T for time of the incidence and time to call 911. Stroke is defined as a sudden interruption of oxygenated blood to the brain caused by either a clot or rupture of the blood vessel. Ischemic stroke is caused primarily by formation of a blood clot, and it accounts for majority of cases. Hemorrhagic stroke is due to rupture of a blood vessel in the brain, which causes either bleeding around the brain or bleeding into the brain. About 87% of all stroke are ischemic stroke. It happens when the brain's blood vessel becomes narrowed or blocked, causing severely reduced blood flow to the brain tissue. A partial or complete occlusion of a blood vessel by an emboli or atherosclerotic plaque reduces or eliminates the perfusion of oxygenated blood to the section of the brain, leading to tissue necrosis. During COVID-19 pandemic, there have been many cases of ischemic stroke related to the effect of SARS-CoV-2 infection. We know that infection and inflammation increases the risk of a stroke. COVID-19 is an infection that produces a strong inflammatory reaction. COVID-19 seems to trigger cardiovascular event and cerebrovascular event, such as heart attack and stroke, arrhythmias, and so on, due to formation of blood clot. Hemorrhagic stroke occurs when a blood vessel in the brain leaks or ruptures, as I said before. Brain hemorrhage can result from many conditions that affect the blood vessel. Although the hemorrhagic stroke accounts for only 13% of cases, but it is extremely serious and life-threatening. Many of these deaths occur within the first 2 days. For those who survive a brain hemorrhage, recovery is slow. A minority of people are able to recover completely or near complete functioning within 30 days of stroke. Factors related to the cause of hemorrhagic stroke includes uncontrolled high blood pressure, overtreatment with anticoagulant, vascular aneurysm and subsequent rupture of the weakened cerebral blood vessel, head trauma, such as patients that are in any kind of accident, cerebral amyloid angiopathy, ischemic stroke leading to hemorrhage. A less common cause of bleeding in the brain is the rupture of an AV malformation. A temporary blockage of blood or blood vessel in the brain is referred to a transient ischemic attack, or TIA, and commonly known as mini stroke. TIA is a brief stroke-like attack that, despite resolving within minutes to hours, still requires immediate medical attention to distinguish it from an actual stroke. Importantly, a transient ischemic attack may be a warning sign of a future stroke. Symptoms include weakness on one side of the body, vision problem, and a slurred speech. These symptoms are usually transient and often resolve within 24 hours. Treatment may include surgery, medications, and healthy lifestyle changes. What are the medical treatment of a stroke? If patients are taken to the hospital within 3 hours of the first symptom of an ischemic stroke, treatment will include a thrombolytic medications to break up the blood clot, such as TPA, or tissue plasminogen activator, is one of those thrombolytic agents, and it will improve the chance of recovery from a stroke significantly. Remember that acronym that I said before, FAST? The T was for the time, the 3-hour window of treatment from the moment that the symptom started. So you have to act fast. On the other hand, for the hemorrhagic stroke, obviously the cause of hemorrhage should be corrected. This could be a surgical management of a vascular bleed, correction of an AV malformation, or surgical clipping, or endovascular embolism by placement of a surgical coil or mesh to manage the brain aneurysm. Surgical enucleation of the blood by opening a window in the skull, if the bleeding was in the tissue surrounding the brain, is the other surgical procedure that would be used to correct that problem. Preventive measures and emergency management of a stroke in a dental practice. If a patient demonstrates any symptoms of the stroke, activate EMS immediately and provide oxygen and monitor the vital sign continuously. If conscious, place the patient in a comfortable position with head and shoulder raised. Support the airway, provide high flow oxygen with a non-rebreathing face mask. Monitor the airway, breathing, and circulation. Remember that although patient may not be able to speak, but will probably be able to understand what is happening, and it will be they would be extremely frightened. A calm management approach is essential. Keep patient NPO. Record the exact time that the incident happened. Continue to monitor vital sign. Wait for EMS to arrive. If not breathing and you cannot feel any pulse, obviously start CPR immediately. Similar to cardiac emergencies, a stroke can occur without any prior symptoms and in patients with no medical history of cardiovascular diseases. However, if the medical history is positive for a stroke, the chance for a recurrent stroke and related morbidity and mortality is much higher. Approximately 3 to 10% of a stroke recurs within 1 month, with an elevated risk of recurrence within the first 6 months. With the passage of time, there is decreased risk of another stroke. Remember that about 33% of a stroke survivor have a recurrence within 2 years. These numbers are essential if we are treating the patient within those periods of time. When possible, dental treatment should be delayed during early months after stroke. Of course, if a patient develops severe infection or pain or had a major facial trauma, consult the patient's neurologist, neurosurgeon, or the primary physician prior to any procedure for guidance. The treatment should be as conservative as the situation allows. You may consider referring the patient to a hospital-based dental team to complete the patient's treatment. Remember that some post-stroke patients may be taking anticoagulant medication, which can cause problem with hemostasis postoperatively. Limit the number of anesthetic carpule used during a procedure on a patient with history of a stroke, but make sure that patient is sufficiently numb and is not in pain or under stress. Sedation with a combination of nitrous oxide and oxygen can be beneficial in reduction of anxiety and as a mild analgesic. These steps are designed to decrease the chances of a recurrent stroke, but do not eliminate it. Quick response and knowledge of each patient's risk will allow for the best possible outcome. For any dental procedure, I ask the patient to never stop taking their prescribed aspirin, Plavix, or any other antiplatelet or anticoagulation medications that they are taking and are given to them by their medical provider unless is directed or they are directed to stop taking them by their medical practitioner. After any dental procedure in patients with cardiovascular or cerebrovascular disease, I give this warning and stress to their right as well that if you had any chest pain, weakness or numbness in your face, arm, legs, or speech difficulty, call 911 and you must be taken to the emergency room immediately. There are many physical and mental residual effects that could occur after a stroke, and we must pay attention to them. Emotional effects such as mood swing and depression, perceptual effect, difficulty recognizing and understanding familiar objects, difficulty planning, carrying out simple tasks, dysphagia or difficulty swallowing, aphasia, difficulty putting thoughts into words and understanding speech. So we need to be caring, compassionate, but vigilant and prepared. Now we get to our last patient and a case of an unfortunate mistake. A 22-year-old patient presented to an oral maxillofacial surgeon for removal of all his third molars under general anesthesia. Patient was sedated with a combination of Versed, fentanyl, ketamine, and propofol. Additional local anesthetic was given. A gauze was placed in the patient's mouth to prevent aspiration. Following the removal of only 2 of his wisdom teeth, he was coughing and bleeding heavily from the side. Several additional gauze were used to absorb the blood. He continued to cough, making choking sound, and moved violently. What do you think the doctor did next? Unfortunately, in that case, he was given additional propofol and muscle relaxant, thinking that this was probably a laryngospasm from light anesthesia. And we know that laryngospasm is a protective reflex to prevent foreign material entering the larynx, trachea, and lung. Soon after that, patient stopped coughing, but he also stopped breathing. EMS was activated. Remember, in a case of complete blockage of airway, patient will develop hypoxia, hypercarbia, and hyperkalemia, which generally could lead to a cardiac arrhythmia and even cardiac arrest. Unfortunately, this patient went into cardiac arrest. So the surgeon started CPR. Sadly, this patient did not have a great ending. Paramedic arrived, but had trouble inserting a breathing tube or intubating the patient. What happened? The surgeon and his team forgot the most basic postoperative step to complete. They forgot to check the airway and remove the throat bag that was placed in the patient's mouth during and after the procedure while the patient was bleeding. So the EMS, during the intubation, packed the gauze in the patient's throat and basically obstructed the patient's airway. So let me finish this section to review signs and symptoms of aspiration as well as choking, and they are as follow. Obviously, patient will attempt to breathe by coughing. You may hear a high-pitched wheeze or stridor. Because the upper airway is blocked, you will see abdominal movement rather than chest movement. Depending on the duration of apnea, patient may become cyanotic and could become unconscious. The first step, just like any other medical emergency, is the prevention. Always protect the patient's throat with a gauze or other measures such as use of isolite mouthpieces or dry shield devices, as aspiration of the teeth and instrument in the dental office are not uncommon. Once emergency occurred, the most important step is to recognize and identify the problem. If you are in the middle of an extraction, pack the site to control the bleeding. Use a Yankauer suction or any other type of suction you may have to check and suction the oropharynx, and if possible, identify the aspirated object and remove it. Have the patient sit upright, bring the head forward, and attempt to remove the object from the patient's throat. Use a gauze or a surgical towel clamp to bring the tongue forward to open the airway if patient is not breathing, and administer 100% oxygen. Always check the airway and remove any packing placed during the procedure. Observe and listen for airway exchange. If foreign object has been aspirated, send the patient to the emergency room for chest x-ray. If there is absolute apnea, positive pressure oxygen must be delivered, and in cases of severe laryngospasm, muscle relaxant must be used to break the spasm, but the surgeon must be prepared to intubate the patient if needed. In pediatric cases, 3 to 4 milligram per kilogram of succinylcholine, a muscle relaxant, could be given in either IV or IM form. Alternatively, 1 milligram per kilogram of succinylcholine could be given intraorally. On the left side of this slide, you can see an aspirated tooth in the upper airway. Placing a throat pack during the procedure could have prevented that. Finally, I have to stress again that to prevent medical emergency, we have to remember a few basic points. Document and update accurate, comprehensive patient's health history. Notice that I underlined update medical history, as it is one of the biggest mistakes a practitioner that knows an individual fails to ask. If you see a patient every 6 months, many things could have changed during that period. They could have had a newly diagnosed medical issue or possibly taking new medications that you must be aware of and take precaution. Patient assessment and clinical evaluation, including head and neck examination and oral cancer screening, must be performed on every visit. You have to have a method of stress reduction and anxiety control prior as well as during the procedure. Use nitrous oxide or sedation if indicated. Some patients may like to listen to their favorite music or even watch a movie as their procedures are performed. Recognize early signs of emergency distress. Continue to look at the patient and talk to the patient. If they are pale, sweating, or getting nauseous, these are early signs of many medical emergencies. If patients are being monitored, reduction of a heart rate, reduction of blood oxygen saturation, and blood pressure could be a warning sign. A written plan of action in case of emergency and review of medical emergency situation and how they should be handled are essential in prevention of emergency disasters. In my opinion, one of the most important preparation to manage medical emergencies is staff training. The time to assign a specific role for each staff member is not during an emergency situation. Assign one of the staff to check the emergency medicine kit for drugs that have expired and make sure that the AED is working properly. The chaos and the panic that can occur among unprepared dental staff can make the difference between life and death. Therefore, each staff member should be assigned to a specific duty during a medical emergency. Contingency plan should be made for the time when a staff member is absent. New staff members should be assigned their specific role when they join any practice. One person should be the designated team leader, responsibility for directing other staff members and performing that initial assessment of the airway, breathing, and circulation should be assigned to that person. It is important that this person has the demeanor to remain calm and relaxed during a stressful situation. A second team member is responsible for bringing the emergency kit, the portable oxygen tank, with an on-demand valve, hopefully, and the AED to the patient. This staff member should be trained to assist with the CPR. A third staff member, if available, is responsible for contacting EMS and providing information about the nature of the emergency situation and the patient's current vital sign. An estimated response time to the emergency should be also recorded. Large practices may have more than one such team, while practices that are just starting may have to divide the duties amongst just 2 or 3 staff members. These rules should be practiced in medical emergency drills on a quarterly basis and should feature the various emergency situations to which the staff must respond. All staff members should be current with their basic CPR training. Some states actually require a higher level of training, such as Advanced Cardiac Life Support System or ACLS, for practices that provide various levels of sedation or general anesthesia for their patients. Now, ask yourself, if you're prepared for emergency situation. Benjamin Franklin said it the best: failure to prepare is preparing to fail. And the final question that I have, what is your emergency plan? Go back on this presentation and listen carefully. And in all of those lectures that I put on for medical emergency, these are really important and life-saving. Lack of planning on your part does not constitute a deadly outcome for your patients. Think about it. As I said, revisit this presentation often as a refreshing course. Share it with your team. I hope that this presentation was helpful to listen to and learn from it. Subscribe to our YouTube channel for our future courses, and please add your comments to our video. If you need to contact me personally, email me at drmmadani@gmail.com. That is drmmadani@gmail.com. Stay informed, stay connected, and invest in your continuing education by following our other courses. I look forward to hearing and seeing your comments. Thank you so much for your time.